All right, welcome to session 2 of our AEMCA prep course. We're going to go through pharmacology down to section 3 tonight. I've put out some notes and practice questions that you can go through to kind of help support this. I'm not going to go through everything in our notes here, but I will go through a few high yield topics. Is there anything, you know what, let's just start, kind of pull the room, get you involved. What comes to mind when you start thinking about testable concepts for pharmacology?
Pharmacodynamics.
Okay. If pharmacodynamics had like a sibling, what would it be?
Pharmacokinetics.
Cool. And then somebody mentioned a term a second ago, mechanism of action. Which one would that fall under? Yeah. So if this is all about how a drug works, there's a bunch of other terms that should come to mind. What comes into pharmacokinetics? We've got a bunch of letters here, right? Maybe that'll help get you started, thinking away.
Absorption.
Yeah, absorption.
Distribution.
What does kinetics mean?
Movement.
Movement. Kinesiology. Okay. Kinematics. Throw the cannonball. Parabolas. Physics. You don't like physics, right? So this is all about movement of drugs. So how drugs get around. So how they're distributed. Metabolized. Is that the same as mechanism of action?
No.
Okay, because it seems like it could be. It's like how the body interacts with it, but this is about how the body gets rid of the drug, prepares the drug to be used, prepares the drug to be used up, and then actually moves the body to the next stage, or the drug to the next stage, which is going to be what? Yeah, I like elimination better. Excretion is more of like a bio-specific word. Elimination is more of like a general pharmacology sounding term. All right, I think before we talk about what a drug does, it makes sense to start here. Absorption, what kind of things come to mind there? Yeah, routes of administration. I'm pretty sure you're probably going to be good to go with those. So instead of just listing things off, if you wanted to ask it, start trying to put things into test question phrase. What is going to be one of the fastest routes? IV. Cool. When I say fast, what am I really saying from a pharmacology term?
Fastest way it gets to the place where it's going to react.
Something that has the quickest onset, right? Quickest onset, not necessarily peak or duration. Okay, the peak effect is going to relate more to distribution and the form of the drug, and the duration of action would also be more drug specific. But the onset would be what we're talking about here. So routes are going to impact onsets, with IV being the fastest. There is definitely a sneaky question I could get you with. What's the slowest?
Is it like dermal?
Yeah, probably dermal. Okay, not only is it the slowest, transdermal would be, when we think about duration, transdermal is probably going to be longer lasting. Not necessarily because of the drug, because duration is still going to really be drug specific, but transdermal patches, typically patches what we're talking about there, are a slow release. Okay, so they have a ton of drug in the patch. So even though the drug's duration might vary, when you're putting a patch on, it's going to keep giving you more drug every minute, every second, essentially, for several days, often like a day or two, up to 3 days. Okay, what are some common transdermal patches? Yep. Transdermal patches could include nicotine, fentanyl, nitro. That's probably good there. Some hormones, yep. If you saw a patch on a patient, would you take it off? It's one of those it depends kind of questions, right? You just, hi, nice to meet you. No patches allowed in my ambulance. Okay, what if they're hypotensive and you find a morphine patch or a fentanyl patch and a nitroglycerin patch, and you're sitting here ventilating and pumping IV fluids in them? Maybe take the patches away. If you're trying to manage an opioid overdose that has 14 fentanyl patches sticking on their body, maybe help yourself out here. You're like, I don't know why I've given 3 doses of naloxone, patch for more. Maybe also ask for permission to take the fentanyl patches off if you're too afraid to. Okay. So these transdermal patches would be very slow. Okay. If I didn't tell you that it was a trick question, or maybe a tricky question, what do you think a more generic answer or a more likely answer you might have given me for a slow route? Yeah, PO. Okay. So those are some pretty big routes. Kind of between these is going to be everything else, obviously. Intranasal, inhaled, very quick. Intraosseous is basically comparable to IV. And then IM is a little bit faster or slower than subcutaneous. Faster. IM will be a little bit faster than subcutaneous. Okay. What differs when you're trying to give a needle IM versus subQ? Just the angle, right? What would that be? That's probably subQ. Draw me IM. Straight up and down. Okay. All right. So that's kind of some different routes. As far as distribution goes, what are some big things we need to think about with distribution? Actually, there's one more thing I think that makes sense to talk about right now. When we talk about absorption, what is a downside of PO? Or could be a benefit depending on what drug you're trying to give. And right, that's a lot of words. That doesn't give me a high yield topic. We could lose some of the medication that would no longer be functional. Okay, so what's a word from pharmacology that refers to the fraction of drug that is actually functional? Yeah, so PO would have decreased bioavailability. Why?
It's subject to the first pass effect, where the liver breaks down a lot of it.
Yeah, it's going to be subject to the first pass effect. Is there really any other routes that the first pass effect happens to? Not really. Okay. I think that I used to mess this up because I used to make notes in my head as like PO has first pass effect, IV doesn't. That's a big advantage of IV. And then I left a big gap in my brain about, well, what about everything else? I think it's better to just realize that the parenteral routes, the parenteral meaning through the skin or like into the bloodstream or injected, are all going to not have a first pass effect. Okay. So what happens in the first pass effect? Why do all my markers do this to me every minute of my life? We might have to use, maybe, I found a bell. Found a new whiteboard marker. Yes, it works great. Okay. What's going on here? There are bloodstreams. Typically in the body, how many capillary networks do we go through on our way from the, you put something in the heart, that leaves the heart through the aorta, goes through a capillary network and it comes back. Okay, so there's typically only one capillary network that our blood goes through. Okay, in a generic, just draw the circulation, there's one capillary network. Okay, everything's in series. So the blood goes through a capillary network to get reoxygenated. It goes through a capillary network to get used. Okay, there's usually one capillary network. There's a few places in our body that have two capillary networks. So not only is it going to go through the regular round and round and round capillary network, it's got to go through a secondary one. Okay, we call that a portal system. Okay, so there's a few different portal systems. Okay, there's one that you don't need to worry about, so I'm not even going to bring it up. It's in the brain. It's got to do with the hypothalamus. It's how your hypothalamus secretes hormones into the pituitary and doesn't just have those hormones act on the entire body as soon as it releases them. It just has a little secret passage to the pituitary. It's called the hypophyseal portal system. And the other area is the hepatic one. And there's one more. Kidney. Okay. Yeah, not just the glomerulus. There's the glomerulus, and the other part of the kidney's portal system is the vasa recta, which go around the loop of Henle. But you're not going to probably get tested on that because nobody ever cares about the kidney. Okay, so portal is probably not a unique word in your brain. You probably came across the word portal when you looked at the liver, okay, and you saw the liver portal vein. Okay, where is this blood coming from? The GI system. And what do we call this set of vessels? All the vessels from the GI system collectively end up funneling into what we call the mesenteric vasculature. The mesenteric vasculature goes into the liver portal vein. That portal vein runs to the liver. Liver does liver things, and it sends out blood to the vena cava to go back to the heart. Blood that's now been purified. So that is the first pass effect. Things that go in the stomach or in the GI system go through the liver via the vasculature and then go to the heart. And now they're in your normal circuit where there's one capillary network at all the effector tissues. So that is the first pass effect. I think while I have this diagram, I'm going to get rid of some of it. And there's something else that I want to talk about while I have the diagram. Not a very great diagram, but this is some free content. If you had drugs and we wanted to talk about the distribution of drugs, we want to talk about how fast those drugs get broken down or moved into a format that they can be used in the body. So what kinds of drugs could exist? How could we classify drugs? Probably two different things we could do to classify drugs into two very large overarching categories. One's going to have to do with something with water, and one's going to have to do something with hydrogen. Yeah, solubility. And what are the two types of solubility? Yeah, water soluble and lipid soluble. What are some terms that you might see just interchanged with those terms? Think about a cell membrane. Okay, they're basically synonyms, and you could see either one pop up in a question. Think about the words that are used when you talk about a phospholipid. The bilayer has a, yeah. Which one's hydrophobic? Lipids are hydrophobic. And water is hydro. Okay, there's one more word that you could maybe see. I actually realize there's one more word you could see for these terms. Something that really likes water, probably has a bunch of groups on it. It would be a molecule that is polar. And you might see non-polar. Okay, so if you're talking about the blood-brain barrier, you might say all of the following are, or if there's a passage that says the following three molecules are all non-polar, which one, and this molecule is polar, which one is most likely to pass the blood-brain barrier? You would want to know, oh, it's, lipid soluble can go through, or non-polar can go through, or hydrophobic can go through. It all means the same thing. Okay? It speaks to some different chemistry properties, but really all those chemistry properties funnel back into the same idea. So those are all the same idea. Not necessarily related anymore, but another way we can classify drugs could be based on their concentration of hydrogen. So we could have two different types of drugs. Yeah, we can have acidic drugs. Yeah. Or basic. Okay. That's fair. You could also call these alkaline drugs. Okay. So, if now we want to talk about distribution and how these drugs get broken down in the body, what is a good rule of thumb we could use for thinking about where certain things are going to dissolve? It's not the same as magnets. Okay, what happens with magnets? I have a positive and a negative magnet. Those are opposites, and they attract. Okay, it's not the same as magnets. When we're talking about solubility, like dissolves like. Okay, not the same as magnets. Okay, like two positive charges don't like each other. They're like, get out of my zone. Okay, but in this case, like dissolves like when you're thinking solubility. So if I have a marker and it's made of plastic and I drop it in water, will it dissolve? No, because plastic is hydrophobic. Plastic is a fat. Okay, plastic is very carbon based, and if you drop it in water, water is polar. It'll hang out in there. Okay, but if I put this into something non-polar, like a hexane solution or an acetone, it will start to dissolve the marker. Okay. So that being said, if I have an acidic drug, where in my little GI system here is the most acidic place in the body? Yeah, the stomach. The stomach has, what's in the stomach? Hydrochloric acid. That's very acidic. Okay, the pH of the stomach is roughly 2. So acidic drugs will dissolve in the stomach. Okay, they will be activated potentially in the stomach. They will break down. They'll be put into the body into an active form or whatnot. Maybe not an active form. The liver might still have to do something to them to make them active, but they will get into the body and not just be the thing you took off the shelf quickly in the stomach. That's why those liquid gels, when you that capsule, that liquid gel, when you swallow it, it dissolves in the stomach, and now the drug is available to be absorbed into the body very quickly. Okay, where an extended release capsule, if anybody's had like an Adderall extended release or something like that, is going to be coated in something that's not going to dissolve in the stomach very quickly. It's going to be coated in something basic. Where do we get a basic area? The small intestine. Okay, small intestine is basic. It's a pH of about 8. So if you had how can you not just learn, but think about this as questions? If I tell you a patient had a surgery that like removed a large portion of their small intestine, or they had a gastric bypass to skip their stomach, what would it do to this acidic or basic drug? Okay, you might want to have that connection in your mind. There are 3, let's ask acidic and basic for you. Think about the stomach and the small intestine. We're scratching the surface on all these things. The good thing is you're studying for the AEMCA and you're doing a college level program, and it's a mile wide and inch deep on everything you learn. Okay, so there's absolutely, that could be a 4-hour lecture. That could be, some people spend their entire pharmacology PhD trying to figure out how to make a drug absorb more in a certain part of the body. But you really just have to know 1 or 2 sentence buzzwords, buzz phrases. Okay. So before I get rid of these, there's a topic we can talk about with these. I don't really have a plan. I have a plan, but I don't use it. I just let the road take me where I go. Okay. So there's a good thing to talk about now, and that would be barriers in the brain. Okay. Oh, I didn't want to say the brain. Okay. Well, there's a freebie. Okay. There's a blood-brain barrier. Where else is there a barrier in the body? Okay, the scrotum, testicles. That's probably low yield relative to the placenta. Okay, you'll find that the AEMCA cares a little bit less about the health of your scrotum and a little bit more about the health of babies. Okay, so there's also the blood placental barrier. Okay, so what kind of molecules can go through here? What kind of molecules can go through these really tight barriers? Fats? Do you think sugars? What happens when you put sugar into water? So if water is polar, sugar is probably polar. Okay. Sugar is also very large. Okay. I can skip all the way down to the very right before chapter 3 in this thing. It talks about parenteral therapy, which is the IV section essentially, and it talks about the difference between colloid and crystalloid solutions. Okay, what's the difference? Both of them are solutions, so both of them are water with stuff inside of it. But colloids are very large things. Okay, and it's not just, well, what's the size? How do I memorize the size? The thing is that when these things go in the bloodstream, colloids stay in the bloodstream, and crystalloids will diffuse. And an example of a colloid solution is a sugar. Okay. Any other ideas you know of colloid solutions? Big things that stay in the bloodstream when you infuse them. Blood. Blood is like the colloid solution. Okay. One more. We were just talking about livers. What's that? TXA is a drug. It's a very small drug. Okay. It acts on the body's like hormone system and whatnot. So I don't know for 100%, but I would imagine that TXA is going to be a very small, like microscopic molecule. Dextrose, so sugars, I said sugars. Yep. Blood, probably not one you're going to get because as a paramedic, you just call it plasma proteins and then you just move on. Okay, but what's the major plasma protein in your body? Albumin. Where's albumin made? If I told you that this patient has a lack of albumin and therefore they have a lack of osmotic pressure or oncotic pressure pulling blood into their, or pulling fluids into their blood vessels. They have no albumin. They've got this vessel with normal amount of albumin, and this person has no albumin. So now there's less things holding fluid in compared to this person where fluid is being pulled in. This person starts to get ascites, start to leak fluid all over the place. So somebody who has lots of fluid leakage, somebody with a liver problem, somebody who has cirrhosis and drinking is my next clue. So yeah, the liver is where albumin is secreted. The liver, we're trying to talk about pharmacology right now, but the liver is, I feel like you chalk the liver up in this program as like the liver does, it filters things. But the liver, yeah, it filters things. It's also the site of gluconeogenesis. It also plays a major role, a very large role in glycogenolysis and glycogen storage. It also creates albumin, which is that plasma protein, which maintains fluid balance. And it also creates clotting factors, okay? So without a functional liver, you're more likely to bleed. Wow, it's great where the road takes us. So now that we're talking about albumin and we're talking about distribution, and we're talking about, so let's just finish the blood-brain barrier so we don't run all over the place. Because there's the blood-brain barrier, there's the blood-placental barrier. Yes, lipid-soluble things can go through. One other type of thing can go through these membranes. Okay. Probably not. I'm sure there are some proteins, but proteins are very large. This is a mesh network. Okay, this is like a network, a barrier, and fat-soluble can just like voodoo, can just go right through there. Okay, can just rearrange the network and move through. Okay, but big things can't get through. So what can get through?
Small things.
Okay, what's the smallest thing you can think of in the body? Hydrogen is technically the smallest thing, yeah, in the world. Okay, we don't make a lot of, there's smaller things inside of hydrogen. We don't make a lot of hydrogen gas, okay, because that's bad for us. I'm sure we do make hydrogen gas probably all over the body, but gases in general is what I'm getting at. So oxygen, carbon dioxide, nitrogen, these things can all diffuse as well. Our brain doesn't need a transport protein. It doesn't need to like open the blood-brain barrier network and be potentially like threatened by poison and sugars and all of these other things, okay, for things to get through, for oxygen to get through and for gas to get back out, carbon dioxide to get back out. So gases, okay? Because they're very small. They're very, very small. If I try to set up a semi-permeable membrane that like doesn't let water or doesn't let salt or something flow over, good luck setting up something small enough to like not let gases go through, okay? It's not that hard. I guess there are ways to like asphyxiate yourself. A plastic bag would do pretty good at stopping the movement of gases, something that's very non-permeable, okay? But the blood-brain barrier, the blood-placental barrier, they let gases just whisk on by. And there would be certain membranes that would stop the movement of gas, but we don't have a lot of them in our body. All right, so now that we've talked about that, I have one last thing before we can get rid of these. How do water-soluble, we were talking about albumin a second ago, so how do water-soluble things get around in our body? Yep. Osmosis and diffusion happen all over the place. Fat-soluble things diffuse as well. They go down a concentration gradients as well. The main way a drug that's water-soluble gets around in our body is in the bloodstream. You have this little wave of blood. Blood is just a fluid, okay? This is just some fluid. And the drug just dissolves in there. Just goes into the bloodstream, just dissolves in there, just rides down the bloodstream. But then you got this guy over here who's super non-polar, and this non-polar thing is just like hanging out, and he's like, I hate water. And he makes all these repelling forces, and he's like, I hate water. I'm not going with the bloodstream. I'm gonna aggregate, I'm gonna all clump together, I'm gonna stay over here, I don't want anything to do with that. How do we get lipids or non-polar molecules that don't like water, how do we get them around the body? What is a transport protein? A major transport protein in the body is albumin. Okay. So we use these very evil words. I forgot my blue doesn't work either. I think that's gonna be my thing. I need a YouTube thing. If I'm gonna have a thing, it's gonna be just, I'm gonna go through just whiteboard marker after whiteboard marker. So instead of using these simple words like plasma proteins and transport proteins, think about what they are. Typically, albumin is a major one. There's tons. But as a paramedic, you'd already be jumping way above and beyond by saying, I know what those are, mainly are albumin, and they come from the liver. So therefore, people with poor liver function, not only do they not filter these drugs well, they have an issue distributing these drugs as well. Not only do they not filter, or another word for filter would be metabolize or get ready for elimination. Okay, tempting. This guy's got 40 whiteboard markers over there now, and I'm very distracted. So this is a great way of starting to think about what type of patient, if you're getting a lot of pharmacology patients. Patients with alcoholism, patients with cirrhosis, hepatitis, okay, liver failure, ascites. Okay. And these are kinds of people who we want to think about the distribution of drugs being very slow or staying on board for a long time. So age, health, these can impact the time of duration. They can reduce elimination, essentially. And they can change the effect. They can either have drugs that no longer can be activated or drugs that take a really long time to get rid of. So we have to be really careful with both elderly and children when we think about drugs. Okay? What's the difference that females have compared to males when we just finish up this topic? Dangerous question. Has an open answer for him.
Are you talking like periods? Is that what
Nope.
No? Okay.
You mean size?
Not just size, but what about the size? Women have a higher, because of estrogen, they have a higher body fat percentage. So because they have a higher body fat, they'll retain and be more susceptible to lipid-soluble drugs. Okay? Older people have less body fat. Really old people start to shrivel up, get really skinny. They have no lipid storage. Okay? So these can all change the drugs. What do paramedics do? What's our number one thing as paramedics? We deal with life threats. What's a life threat that could impact distribution? Hypovolemia, okay. Or more broadly, this time I'll allow the word shock, okay? Instead of getting into specifics, if you're in shock, if you're in a state of hypoperfusion, you're not going to move drugs around very well. Which is why it might be a questionable idea to be giving, IM injectable epinephrine into a periphery while someone's dead. It doesn't hurt, it doesn't take a lot of time, and we're doing the CPR to move all that stuff around. So if you just gave IM epinephrine to somebody who was dead and never did CPR, it would be very unlikely to have any kind of impact. If you just give naloxone to somebody who's not breathing, it's very unlikely to have any kind of impact. Has this thing flashed green at all? No. Good. All right, metabolism. Let's get into metabolism. Where are the drugs metabolized? Maybe they're not. Some drugs come in, they do their effect, and they leave. Where else could they be worked on? Liver or kidneys. Bring that back to the words that we just used. In general, very high level, in general, what kind of drugs are dealt with by the liver? Fat-soluble ones. Yep, and drugs. The first pass effect will reduce bioavailability, but at this point, the drug's in our body, and we're talking about how we get rid of it, or how we activate it, or how we use it. So all drugs will eventually go to the liver if they need to be activated, or changed into a different format. So some drugs are fat soluble, and we are full of fat, men or women, we're full of fat. So we will just keep a lot of fat soluble drugs in our body for a long time. So what the liver will do, essentially, again, you could spend hours and hours talking about this, and I'm not the smartest person in the world, and I have no idea what I'm talking about if I try too hard, so we'll keep this superficial as well. The liver metabolizes things and turns them from fat soluble into water soluble. That way they can be excreted in the feces, they can be wrapped up in some bile, or they can be passed into the bloodstream to be just filtered through the kidney. So a lot of metabolism by the liver is just trying to turn this into water soluble, essentially. If you want bonus points, you will probably be right anytime you spin the roulette table on what part of the liver metabolizes this drug if you just say cytochrome P450.
Just lock that.
Okay, just locked it down. There's a giant chain of enzymes, and it's involved in metabolizing tons of drugs. Okay? If you start reading into the drug sheets, you will find that it's almost always like, oh, in the liver, the P450 enzyme chain just does something to this drug. Okay? Kidneys are therefore going to get rid of what? Yeah, because we remember the drug in the blood goes to the kidney, and the kidney filters things out. Okay? And how does the kidney filter things out? It has the glomerulus. And the glomerulus just has small holes in these capillaries. Okay? And then small things can leave, but big things like plasma proteins, sugars, okay, large vitamins, they're all going to stay in the bloodstream. But little things like salts and little things like drugs, often drugs are very small, can escape into the nephron. There is something in here that I'd never really heard of, but I kind of had heard of. Does anyone know what the hepatic microsomal enzyme metabolizing system is? Because the Ministry of Health would like you to know what that is. And I was like, fat chance you interview a random paramedic off the street and say, yes, I don't even know what that is without turning around. Do you know what the hepatic microsomal enzyme? Ask your preceptor that. Write that one down on a sticky note. First day, be like, hold on, before I can trust learning from you, I need to know if you know what the hepatic microsomal enzyme metabolizing system is. If they don't have a good answer, be like, not sure you're the preceptor for me. 3 a.m, I want you to be thinking of that. Okay. How is alcohol metabolized? Ethanol, all, is water soluble or fat soluble? Can it go into our brain? Yeah, it can go into our brain very easily. That's what makes us drunk. So we know it's fat soluble. It passes the blood-brain barrier, no problem. Okay. So ethanol does not get excreted in the urine because it's fat soluble. Okay. So ethanol must be metabolized by the liver. Ethanol is metabolized into aldehyde. That's nasty. That'll mess you right up. That's poison. That's what makes you feel like terrible. Okay. So ethanol goes into your brain, makes you feel drunk. Aldehyde is the first step of conversion, makes you feel terrible. And then we turn it into acetate. And acetic acid and stuff, that's like probably in a lot of candies and sugars and fats and things you eat. So that's not really bad. And that's water soluble. We can get rid of that. Okay, there's a couple of enzymes that happen here. And there's this thing called pharmacokinetics. Okay, it talks about rate, kinematics. Okay, there's a rate of all these different reactions. This is way beyond the scope of what you need to know, but it's kind of the foundation of being able to say, I do know what the hepatic microsomal enzyme metabolizing system is. This is the normal cytochrome P450 pathway. Okay, checks out, it works. Okay. And it is what we would call zero order. Okay, you don't have to write that down, but zero order just means constant over time. It just means that the rate of this is constant over time. You do know that. That sounds super sciencey, but that's the advertisement that says, not coffee, not water, not being slapped in the face, nothing can sober you up faster, okay? You need to wait. Don't just wake up in the morning and drive to your paramedic interview hammered. You're like, I had 4 espressos, I'll be fine. It's like, no, this is a zero order reaction. The only thing that affects it is time. It's a constant metabolism over time. Okay, well then, if this is true, if there's this metabolism pathway that's normal and it functions so we can make something really bad turn into something that's easy to excrete and it's constant over time, how come when I have 2 beer, I end up drunk and my drunk Uncle Jim can drink like 12 beer and he's just like, doesn't even seem drunk. Okay, he's just fine. Okay, so that is the hepatic microsomal enzyme system, and basically a different pathway can metabolize this stuff. And when this other pathway metabolizes it, it's less efficient and it's messy. We're just going to call it messy. Okay, it's less efficient. It's a little bit messy. It causes more harmful byproducts. Okay, it damages the body more, but you can upregulate this system, this microsomal enzyme processing system. So people who drink more end up making more of a secondary enzyme system. They upregulate that system and they can metabolize alcohol at a faster pace. The reaction is the same speed, but they have more enzyme. So they have, this factory makes 1 pair of socks. They don't make this factory make 2 pairs of socks a day. It still makes 1 pair of socks. They open another factory with like more sketchy workplace health and safety conditions. Okay. So they also put out 1 pair of socks a day, but they also have some casualties at work. All right. So it's not as efficient and clean as the cytochrome P450 pathway, but you can, at the end of the day, get more socks. Okay. It's not tolerance per se because we're upregulating the amount of enzyme to get rid of it, So if we jump into tolerance, which is something I do want to talk about as well, when you have a cell, and this cell is hanging out, and this cell has receptors on it. Okay, that's me when I don't wear a toque. All right, and when we have 4 receptors because we want to say, like, have a chance. Let's say we have artificially, we say there's like a 25% affinity for something, and we want to be able to like make sure when a molecule comes by, we get it, okay? This is like a dopamine receptor, okay, or something like that. So we're like, oh, there's a dopamine, I hope I get it. So I have lots of receptors for it. And then all of a sudden, we just want to make sure that like 1 of every 4 receptors grabs it or whatever. We just need some kind of math so I can explain this concept, but it's not really how that works. And then all of a sudden, you're like, I would like to try crystal meth. So it seems like a great time. Finals are over. Let's do crystal meth. So now your presynaptic neurons are like, okay, have more dopamine. And they go and they get rid of MAOI. They get rid of all of these things. They block the reuptake channels. They're like, you just have dopamine. And your body is like, wow, dopamine, 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 dopamine. This is awesome. I love this. Well, now, over time, your body is like, this isn't really the standard. I don't really like having this much dopamine all the time. I think something's going on, and it down-regulates the amount of receptors you have. So now, you need more drug to try to hit the same amount of receptors to get the same effect. So when you're talking about classic tolerance, it's typically chronic exposure to the drug overstimulates the receptors. The receptors are like, this is too easy. The cell says, I don't think I need that many receptors anymore, except receptors, are causing too much of an effect. It's costing me money to make these things. I'm going to make, what's that? It shuts down some of the sock factories. It's like, I don't think, well, it keeps the same factory, but it fires half the workers. Okay, it's like, you know what, you guys can go home and never come back. We don't really need you. We seem to still be putting out a set of socks a week. And then all of a sudden, no crystal meth, no dopamine, and you're like, another 1 dopamine molecule comes by, and it doesn't have a strong enough affinity. It doesn't have enough receptors. You don't get that effect anymore. Okay, so now you have withdrawal symptoms. Okay, you mess with everything because your receptors are no longer optimized to exist without the drug. So you need the drug to stimulate the cell. You need higher concentrations or lower concentrations, depending on the drug. You need more of the stuff to stimulate the receptors. Okay. So if that was pain, and this is endorphins, these are endorphins, and I'm like, ow, this is my ow signal. Okay. And I get these little endorphins come along occasionally, and I'm like, no ow, that's good, I like this, no ow. And then all of a sudden, we get so much fentanyl and so much opioids that we get into that same idea where we're like, okay, I don't think I need 4 receptors anymore. There's opioids all the time. And then all of a sudden, you don't have opioids, but now you only have 1 endorphin and 1/3 of the receptors. You're more likely to allow this ow cell to just be like, ow, 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 where's my thing? You end up with a massive amount of pain. That is tolerance. Metabolism, I think we're good here. Otherwise, I could just keep talking about pharmacokinetics forever, okay? Absorption comes through various routes. Think about the first pass effect. Distribution, we need to think about fat solubility or water solubility. There's various words for that. Metabolism happens in the liver or the kidneys. And elimination is going to be how you get rid of drugs, which is going to be in the feces, exhaled, sweat out, stored in your fat cells, burned, and eventually all the same process, or just urinated out. There's one last topic that needs to be talked about when we talk about elimination. You have 1,200 milligrams of drug in your body, and 4 hours later, you have 800, and 6 hours, 8 hours, 10, 12. Okay, 6 hours later, you have 600. 12 hours later, you have 300. What's going on here? We're losing half the volume of drug, half the mass of drug every 6 hours. Okay, so that's the half-life of a drug. And the important thing to know is it doesn't mean that in 6 hours I get rid of half, so I got rid of 600, so in 6 hours I get rid of another 600. No, half-life. every half-life you get rid of half of what you started with. Okay, so if we had 1,200 milligrams of drug and it's a 6-hour half-life, I don't care about 4 hours, I don't care about 8 and 10. I know that at 6 hours, I'll be down to 600. At 12 hours, 6 hours more. 6-hour difference, I'll be at 300. So when's my next point that I'll reach half? 18 hours, and how much drug will I have? 150. And how much longer? Okay, and I'll be at 75. And you're like, so technically, once I do crystal meth, I never have no crystal meth again? Yes, you just invented calculus. Okay, you never really, the limit does not exist. Okay, you're just going to keep having and having and having until you're finally mentally okay with rounding to 0. Okay, so if a drug needs 100 milligrams to do its thing, and there's 3 different versions of the drug. Okay, one of them requires 120 milligrams to kill you. One of them requires 50 milligrams to kill you. Let's give one more. Okay, there's 4 different drug versions. They're all, painkillers, and they all need 100 milligrams to do their thing, but they have various amounts that would kill you. What should we label these terms? This would be our dose, and these things that cause harm would be our, this is our therapeutic. I like effective too, that works. This is our therapeutic dose, and this is our toxic dose. Okay, and there's something that I feel like would be so easy to make a multiple choice question on, called therapeutic index. Over time, I will work on color consistency. Right now, I just like to change markers a lot. Okay. Therapeutic index is going to be a formula. You're probably just going to want to memorize it. You could sit there and work it out. It would probably eventually make sense. Okay, therapeutic over toxic is going to equal a number, an index. Okay, since this is milligrams or volume or mass, these cancel out. This is just a number. Okay, there's no units for the index. So what are our indexes? Let's see, we've got 100 over 120 equals. We've got 100 over 50 equals. We've got 100 over 300 equals. So this is like 0.8, this is 2, this is 0.33, this would be like kind of 1.15-ish. Okay. I think my notes are backwards. Therapeutic dose. Yeah, so you want a higher number. Okay. My notes are backwards. My notes have the values wrong. Closer to 0 is better. Okay. Once you're getting closer to 1, you are getting into a more dangerous territory. Okay. Because I need 100 milligrams to do my job, and I need 120 to die. Okay. So if we had 100 milligrams therapeutic and 100 milligrams to kill me, that equals 1. So 1 is bad, because that means you got a 50% chance of dying, you got a 50% chance of getting the effective dose. Okay, these values are actually 50, and you might remember the term LD50, which is the amount of drug that will kill you 50% of the time. So you're not guaranteed to get the effect, you're not guaranteed to die. These values are referring to the average person 50% of the time will have that effect. So when the number approaches 1, we have a very dangerous drug. Okay? So this drug that needs 50 milligrams to kill me and 100 milligrams to work is not a safe drug to take. Okay? You're taking 2 times the lethal dose, okay, to get the effect. So you want something like this where you have 600 milligrams to die and 100 milligrams to have a nice headache relief. So a lower therapeutic index is better. I would say 1 is not acceptable, and I would say anything close to 1 is not acceptable as well. All stuff I probably maybe should have taught you in pharmacology. It's probably in a slideshow. I maybe taught pharmacology once upon a time. I'm gonna have to make new slideshows. I might just teach with a whiteboard. I don't know if they're gonna like it. Do you think I could pull it off, just teaching with just straight whiteboard?
Depends on what class you're in.
Pharmacology and selected topics.
Yeah,
Oh.
what classroom?
I'll just bring out, didn't we just bring a whiteboard last time?
just stole it from
Yeah, we'll just get the whiteboard from WebJack again. We just brought it in. The lecture hall didn't have a whiteboard for the whole semester.
The same ones that we
Tell
had
me you went to
selected?
trend without telling me you went to trend.
Why?
Jack.
Oh, wee tongue. Whatever. The lecture hall. Okay. Before I get into mechanism of action, that's fine. Let's do mechanism of action, and then I'll jump into what else I wanted to talk about. Good. Yeah, we'll do mechanism of action. Basically, pharmacodynamics, how the drug works. That's what it binds to. That's the thing that you've stopped thinking of these 2 words for the last semester. Okay, you thought probably about these words a lot when you were doing pharmacology, but now you're just like, what does nitro do? You asked me the other day, you're like, what does nitro do? It's like, oh, it inhibits phosphodiesterase, nitrous oxide in nitro gets released, activates CGMP, decreases intracellular calcium levels. That's the mechanism of action. Okay? What does a phosphodiesterase inhibitor do? Oh, it does the opposite of nitro, okay? Or the similar things or whatnot. Whenever you're getting into what these drugs do, a phosphodiesterase inhibitor does the same thing as nitro. That's why they're contraindicated, because they have a synergistic effect. But when you talk about opioids binding to the mu receptor, epinephrine binding to the beta-1 receptors, that's always been you studying mechanism of action. Okay? The mechanism of action is what your drug does. If we're just talking about a high-level thing, then I would probably want to talk about skateboarding. Okay. I'd probably want to talk about active site. Okay? I thought it was a half pipe. It didn't go over very well. I thought that was a great joke. I don't know. Drawing a half pipe, okay? You get your guy right here. He's ready to drop in. See it now? Okay.
I thought I was another one of your wide tangent analogies. I just wanted to make sense.
He's ready to skateboard, okay? So the skateboarder breaks his leg, and now he needs pain medication, okay? So if a drug, we don't actually know that this is how things work. We're pretty sure this is like the steric theory, or the theory of things fitting, the lock and key theory or whatever, okay? This would be called the active site. And the drug is going to fit in there, okay? The degree at which there is an attractive force, not necessarily just physics, but not necessarily just magnetic or whatever, but the degree that the stickiness, we call the affinity, okay? The stickiness, how sticky, how likely it is to bind is called affinity. Okay, so something with a higher affinity, we need less higher affinity means we need less. Ooh, that's a fun shape. Less concentration to obtain binding. Okay, so affinity talks about how likely a molecule is to bind. Something with low affinity, not likely to bind. Still can. It's just you'd probably need a whack load of it to get it to bind enough to actually notice an effect. Something with really high affinity is going to you won't need very much of it to get an effect. Okay. So what we can have happen is we can have something come in here and block the site. Okay, we would call that an inhibitor. Now the poor sad golf ball can't get inside, it can't cause the effect. Okay. This inhibitor is bound not to the active site. Okay, it is bound somewhere else on this enzyme or on this molecule or receptor or whatever. It's bound over here. Okay, so it's not bound at the active site, it's bound there. So what we would call this inhibitor is a non-competitive inhibitor. It doesn't compete for the active site with the molecule. It just makes it so that the rate goes down. Okay. Then this little cone head thing comes over here and it starts to go in there, and it has, let's say this guy has an affinity of 5, and this little teardrop looking thing has an affinity of 3. Okay. In this case, they both want to hit the active site, but this cone shaped thing, teardrop shaped thing, I don't know what to call this, doesn't do anything, no effect. It just hangs out. It just like wants to chill there. Sometimes some people hang out in the smoking section. Doesn't mean they have to smoke. And then someone comes by to smoke, they're like, you're in my way, get out of here, okay? I belong in the smoking section. I want to be in the smoking section more than you. You're just chilling over here. You don't even do anything over here. Okay, so that's this guy. He's just hanging out in the smoking section. He doesn't quite fit well enough, but he's competing with this molecule for the active site. Okay, so in this case, this is competitive inhibition. Which means competitive. It means this guy can compete with him, and if there's enough of this, this will be irrelevant, okay, because this has a higher affinity. So this guy will come by and be like, get out of here. And this guy will pop off and go over there. They'll be like, oh, sad, I wanted to go in there. And then this guy will come in here and carry on. So a competitive inhibitor will not impact the rate. It will just impact how much you need to get to that rate. Okay, so you could take more drug and it would be fine. Okay, and then what other terms do you guys use for it in the paramedic program? Permanent or irreversible, or what is it? What do you talk about opioids and naloxone? You say one is like a temporary inhibitor, or what term are they using for naloxone? Nonetheless, doesn't really matter. Just realize that these things could last for different amounts of time. So the amount of time that this inhibitor lasts could be longer than the molecule it sticks around for. Yeah.
What is the difference here between like competitive antagonists?
These are both antagonists. Okay. Both things that compete for the site. Both things that compete for the site would be antagonistic, but one would be reversible, I suppose. One would be the competitive one, we can reverse it. Okay, and the non-competitive inhibitor, we can't do anything about it. Okay, so both of these forms are antagonizing the effect. Okay, where something that increases the affinity or makes this more sticky or makes this molecule move in such a way or get modified in such a way that it wants, it would be an agonist. Anything that promotes the effect. Okay, and that in this context we're talking about what I was just talking about, making this work better, would be supporting something endogenously, but you could also just have a drug that you give that just fits the exact same way. And that would also be an agonist. Okay, so that's, I got an affinity of like 4, and it's not that blue thing, but it works and it does do something. He smokes too, he vapes. Okay, this guy comes over, he's allowed to hang out in the section, he vapes. It's not normal, it's not normally what happens here. Normally we smoke, but like you can stay, you vape. Where the other guy was just kind of over here, and he's like, taking up room, and there's not a reaction happening, there's no smoke clouds, and then like people can kind of push him out of the way. But then the principal can come out and be like, I'm shutting down the smoking section. No one will smoke today. Okay, and that's a non-competitive inhibitor or a non-competitive antagonist. Non-competitive sounds like a trap word because you're like, oh, it's non-competitive, like it doesn't do anything. It's just saying, no, it just doesn't compete in its method of inhibition. It still inhibits, it just doesn't fight for the active site. It causes some kind of conformational change or blocks the active site. So carbon monoxide is a competitive inhibitor of oxygen binding to hemoglobin, right? When we have hemoglobin hanging out here, and we want to get our oxygen on, but carbon monoxide comes and hangs out. With enough pressure and enough concentration of oxygen, we can bump these carbon dioxides back off. Okay, so that's a competitive antagonism. We're not letting the normal reaction happening, but with enough stuff, we can again. That's essentially your pharmacodynamics. If you're good with like the idea of antagonists, receptor shapes, how things bind, then every drug has its own specific little paragraph you would put with it, but you would just be talking about that. So a beta agonist, a beta blocker, those kinds of different things. If we have some time at the end, and you're still sticking around, I'll go over a few different things. The last thing I want to talk about from high yield things There's just a few graphs. If you did the questions, you're probably good to go. I don't know how many graphs I need when I do this stuff. I just like to draw a lot of them because I figure I'll probably need more later. This is dose, and this is effect. Who knows where I'm going with this? We're learning about the two terms, potency and efficacy. Okay. If somebody farts and you can smell it from really far away, what would you say? Oof, that's potent. Okay, didn't need a lot of that before I realized what was going on. Okay, and if somebody's like, the whole class is losing their mind, you're all chatting in the lecture hall, and I'm like, one more word, everybody gets a 0. Everybody goes quiet. Like, wow, that was very effective. That really did what I wanted it to do. Okay, so these are different things. Okay, I might smell that fart and still not leave your house. Okay, it was potent. I knew that it was there. Didn't need a lot of fart before I knew what was going on, but it might not be effective. If you drop that fart to get me to leave, I might still stay. Okay, but there's some sense, maybe a stink bomb, that's more effective. Okay, or tear gas, something like that might be more effective at getting me to leave. Okay, so if your chart is set up like this, I don't want to encourage you to memorize things, but I want to move somewhat quickly. If your chart is set up like this with dose on the bottom and effective on the top, things that are more efficacious are higher. Okay, they have more effect. Okay, so drug A is red, drug B is blue. Okay, so they require the same dose. They have the same dose, but they have different levels of effect. Okay, so this is, you could say this is Tylenol, and this is morphine. Okay. I don't know that their doses are actually accurate for that, but we're just talking about the effectiveness. Morphine is better at relieving pain. You might see a chart set up of like pain reduction of 0 to pain reduction of 10, pain reduction, and morphine is reducing pain more. Okay, it's taking 7 points off the pain score compared to Tylenol, which is not. Okay, then let's say we look at 2 different opioids, and we say, okay, these opioids are the same. They both top out at this effect. Okay, but drug B, you require a lot more opioid to get the same effect. Okay, the red drug is more potent. We don't need as much of it to accomplish the maximum effect. Okay. Spend some time with those. Could be a very easy test question. Okay, no guarantee you get any of the questions I talk about, but also you could get like 2 of them or 3 of them. Like you just get a few charts and you'd be like, efficacy and potency, I never went over that since 2nd semester, and now you're in a bad spot. These are what I would call high yield concepts because they're very easy to learn, but they're very hard to figure out in the moment. Like if you get efficacy and potency mixed up, that's a point that you're not going to be able to get yourself back, even if you can see the chart and you can be like, I can tell what's happening here. One drug does more than the other. Like if you don't have the little lingo for it, you can't get yourself through it. And most of the paramedic tests, most of the AEMCA is going to be knowledge-based. Okay? There's going to be a lot of your patient care style like scenarios with 5 questions, but a lot of it will just be like, do you know it or not? Okay. All right. Is there anything you guys want to talk about? Talked about everything I think I wanted to talk about other than getting into, let's just scan this. I have things to go through, but let's just quickly scan. If you're following along at home, I've got pre-hospital syllabus notes posted that you can go through. Okay, so it talks about distinguishing pharmacokinetics, pharmacodynamics, the different types of names, the rights of drug administration, onsets, therapeutic doses, a few Latin terms that probably are pretty low yield, routes of administration, distribution, flow being increased. This comment here about increased flow being increased drug, that's the shock comment. If you have no blood flow, then you're not going to get a lot of movement of the drug. Okay, albumin is a pretty high yield topic for pharmacology. Talking about blood-brain barriers. Remember that astrocytes form the blood-brain barrier. It takes time for it to grow. Okay, if you're going to get teratogens into your placenta, it's more likely to happen early on. Okay, some things are teratogenic throughout your entire pregnancy, but it would take time for that blood placental barrier to form as well. From a pharmacology perspective, Ray's syndrome is when aspirin gets into the baby's brain, causes a buildup of bilirubin in the body, and bilirubin's able to get through an unformed blood-brain barrier. Okay, could come up, but it's also like a 30-year-old question, so I wouldn't be surprised if we're moving on, hammering into people that you can't give babies aspirin. Although I guess you're still coming into the program and you should still know not to give babies aspirin or ibuprofen. Okay, you need children's versions of children's Advil and whatnot. First pass effect, water solubility, differences in age, gender, body weight, if you have one kidney, if your kidney doesn't work, if you're missing half your liver, if you drink 3 bottles of tequila a night, these things are all going to impact your ability. Talks about antagonism, efficacy, half-lives, synergism, potentiation, you're good with those ideas. 2 drugs that both do the same thing may have a bigger effect than either one of the drugs on their own. Okay, we talked about tolerance. When you see the term habituation, it's talking more about it's talking more about psychology than biology. Okay, so sometimes you might hear about somebody who overdoses because they do a drug in a different place. Okay, or you might feel like you get really stoned at your friend's house, but not so much in your garage where you get stoned all the time. Can be, but you're like, I didn't build tolerance between today and yesterday. Sometimes you feel more stoned out and about or at your friend's place because of a psychological thing called habituation, where your brain just gets really comfortable at doing drugs in the same environment, so it doesn't notice the difference in your body as much. Okay, that actually can lead to overdose. People do cocaine in a different setting, okay, and all of a sudden they have like a huge overdrive and they have a heart attack or something like that when they did the same amount of cocaine. Their body wasn't prepared to down-regulate things, or to, they're out at the library doing cocaine, so their body's like, oh, I'm gonna get caught, and it releases more catecholamines because they're anxious and they're this and that. Like, they're not in the same setting. So that's the difference between habituation and tolerance. Tachyphylaxis is just a fancy pharmacology word for very rapid developing tolerance. I thought it was just hallucinogens. That was the first thing that came to my mind. It's very hard to do mushrooms like 7 days in a row. You'll build a huge tolerance to mushrooms and hallucinogenics very quickly. But when I was looking up some other examples of that, nitroglycerin, probably going to lose your blood pressure before you build a tolerance. Okay, so I'm not saying to 6-tap the nitro, but you will build a tolerance to nitroglycerin fairly quickly. Salbutamol, you'll build a tolerance for as well. Could be an influence of why we give 8 sprays to people, because maybe they've been using their salbutamol a couple of times and we really want to get an effect, and we want to make sure that they're not just tolerant to their 2 to 3 sprays. Okay. Talks about a few different words here. Teratogenicity, teratogens messing with the fetus, mutagens messing with the DNA. Carcinogenity, I feel like I was like, come on, that's basically the same thing as mutagenicity. Specifically, mutagens mess with the DNA sequence, which could very well lead to cancer, where a carcinogen is going to cause like an oncological factor or cause unregulated cell growth and differentiation. An idiosyncrasy is just a fancy pharmacology word for I didn't expect that to happen. So you give somebody a drug and they have the 1% reaction that like barely anybody ever has. That would be like an idiosyncratic reaction. Okay. Talks about, and then this is where they get you. This is where they get you if you're just reading the pages and you're like, oh, I got 1 page left and I'm gonna go to bed. And they hit you with a line like this that says, for every drug in the PCP core medical directives and auxiliary directives, provide the rationale for all of the directive. You're like, wow, that's a 2-week study point now, right? That's not a 2-sentence study point anymore. So a couple of examples I came up with real quick is, why are we not giving NSAIDs or analgesia to somebody with ischemic chest pain? Why would they put in there not to give NSAIDs for ischemic chest pain? Well, you're like, because it's not the most appropriate drug. I also have aspirin. I want to go to the cardiac ischemia directive for that. Okay. Why can we give nitroglycerin when somebody's altered for PE, but we can't give them chest pain or nitro for chest pain when it's just cardiac ischemia? They have to be unaltered. Why did they put in that kind of thing? Okay. Talks about, we could talk about that in a second. Why do you not give Gravol to people who are over 65 years old? Okay, so if you don't feel comfortable like having a couple answers or a conversation with that, these are definitely an area you're going to want to study. Make sure you understand the why of the directives, not just the what of the directives. Okay, and then it gets into what pharmacology class actually was. So I picked a few of these that might be worth talking about if we stay for another little bit. Basically, it just says, what does every drug in the world do? It says like, talk about, all of these different types: antagonists, opioids, neuroleptics, adrenergic agents, bronchodilators, corticosteroids, cardiac glycosides, antihypertensive, diuretics, antidysrhythmics, antianginals, platelet inhibitors, anticoagulants, antiemetic. It talks about every class of drug. It says, did you ever do a pharmacology course? Okay. They hit you with another big one-liner here. Okay. Describe the actions, use, contraindications, adverse effects for every medication in the ALS PCS. You're like, oh yeah, that's a flashcard. or a lot of flashcards. That's why I tell you to use Anki, because otherwise you're gonna be the Dollarama's like favorite customer. You're gonna show up like 6 months before your AEMCA and you'll be like, I like all the flashcards. And they'll be like, this guy in a bow tie actually just came by. He had a bow tie and a toque and he bought all the flashcards. So you guys are gonna be like 60 paramedic students fighting for a very limited supply of Peter Rose flashcards. Or you just won't study and you'll be like, that's not a me problem because I'm not gonna study. And that'll be fine as long as you get at least 70, okay? But sometimes people fail AEMCA, and that I don't think really matters because you can write it again. And I think you can write it again. But if you fail 3 times, you have to retake the paramedic program, which is expensive. So at that point, you might want to consider just taking a different program. Or, hey, come hang out. Come hang out. Hopefully you have a plan for your 4th write, okay? I think if you retake the program, you probably get 3 new writes. I'm not sure though. They might cut you off after 1 if it's your 4th take, okay? And then it goes and hits you and is like, make sure you know the use for all these super high yield things like diuretics, ACE inhibitors. Okay, so lots of stuff here. We can go through a few higher yield things. I think we should while we're all here. But this 2 pages is 15 weeks of your life. I'm familiar with the curriculum of the pharmacology class, and this is 15 weeks of your life. Okay. And I tried to make sure when I teach pharmacology that I was hitting this part about the ALS PCS standards. There's like 2 lines, but would probably be worth teaching. Okay. So we can go through some of that. And then it jumps into parenteral therapy. I think we can actually just get through this really quickly. I'll go back here so that my YouTube video is not me just abandoning the camera. But we're basing this whole course off of the Ontario Pre-Hospital Care Syllabus. So it talks to risks with doing IVs, needle sticks, because they're career enders for people and they cost tons of money. Just remember that gauge goes the opposite way of the needle diameter, okay? Unlike French, okay? And what do we use that's French? We should know all of our equipment as well, so. ET tubes is millimeters, but the suction that goes in them is French. And what's a first semester thing we use that's measured in French? Nasopharyngeal airways are measured in French, 26, 30, and 34 French as well. Okay, so bigger French, bigger thing. So a 34 French nasal airway is bigger than a 26 French. Okay? But gauge is the opposite. We talked about this method used for sub-Q versus intramuscular, just 45 versus 90. Okay, why might you want to go intramuscular over IV? It's not going to matter for you guys, but I think controlled substances are coming to PCPs next year. So if you get hired, then the April CME, apparently, they told us this for 5 years, so I'm probably wrong. Do one of those, like remind me in 6 months on the comments. That would be like, when you get hired, your first CME is probably, okay, you're going to give morphine, you're going to give fentanyl, and you're going to give midazolam. And that starts to bring open the conversation of like, why would you want to just give your midazolam IM versus IV if we know it's more effective IV or quicker or whatnot? And it brings in the idea that you could miss your IV. So although there's a slightly delayed onset with IM, you really can't miss an IM injection. You can, and that's bad because it went in your own hand. Okay, I'm just getting flip the bird here in the first row. Okay, so we might prefer to go IM instead of IV because we can't miss. Okay, so although there's a longer onset, we can guarantee that it's going to be 10 minutes from now that the drug takes effect. Where if it takes about 5 minutes to 10 minutes to set up an IV and you miss, well, now you're looking at 5-10 minutes for your second IV, and then you miss, and eventually you're like, okay, I'll just give it IM, and now you're way further down the football field here. Okay, drip sets, the drip math. Why we'd want to use a Buretrol, just for more accuracy. A big thing I think is worth talking about. I feel really bad still because I had a call the other day and this lady had a blood pressure of like 80 on 40, okay? Which is not, you're like, that's not that bad. 80 on 40, 80 is not that far below 90, okay? So you're like, that's cool. Who knows how to calculate MAP off the top of their head? Soon you'll have a cardiac monitor and it will tell you. Or you can do systolic blood pressure plus systolic blood pressure minus diastolic blood pressure divided by 3. But that seems way more confusing than doing this. So we're going to get rid of that right now. That plus sign can really mess you up. Okay, so that's 80 plus 80 divided by 3, 160 over 3, 53.3-ish. Okay, 53.3 is a very, very, very bad map. Okay, if you're thinking map, what's the magic number? Greater than 60, be nice. Greater than 65 is probably a little more generous to the organs. So yeah, it's just 80 on 40. Okay, it's just 80 on 40. That's not that far below 90, but the problem is the 40. Okay, the problem is the 40 for sure. Okay, so that's a map of 55, and I was like, I'm going to give this lady some fluids. And my partner was like, she has crackles and a history of, this is a complex call, and I think that as far as the right answer goes, a bag of fluids is not going to fix somebody, and also it's definitely an ICU level problem. We have this patient, 80 years old, felt unwell for a week, feels lousy, looks lousy, feels unwell, has been like dry heaving, no source of infection, no UTI symptoms, no fever, not actually bringing anything up, refusing food, refusing water, okay, drinking like this much water a day, but also not taking her diuretics, okay, not taking her Lasix. But then her ankles aren't that swollen. Daughter says, oh no, they've been way more swollen. They're fine now. Her legs are fine. But she does kind of have like pitting sock lines. So you're like, okay. And she's got fine crackles. So she's got fine crackles. She's got minimal edema, decreased Lasix input, decreased water input, a map of 55, and my partner's like, yeah, we can't give her fluids. Sorry to burst your bubble. You're not giving her fluids. He didn't explicitly say that, but he's like, we can't do that. She's got crackles. And I'm like, who cares? Her blood pressure, her map is 55. She has no fluid in her vessels at all. She looks terrible. She looks incredibly lousy. She's dying, and she needs a fluid challenge and probably vasopressors. Okay, but to give dopamine, you need to be STEMI positive and hypotensive to be your cardiogenic shock directive. But she's a left bundle branch block, so you can't tell if she's STEMI positive or not. So I probably would have been able to justify a patch, but my partner's not on board. My partner says, contraindicated fluid overload. And I say, how is she fluid overloaded? She hasn't drank any water in like 3 days, which is not ideal for a human being. I drink like 4 Nalgene's a day. This lady's drinking like this much water a day. Okay. Well, she's on a decreased Lasix. This is a very complicated call. This is very much like a decision that's like, just take her to the hospital. You're not an ICU doctor, okay? But I think that the point of what I'm getting at here is it talks about signs of fluid overload. And what it says in the directive is signs of fluid overload. Okay? And I think we get really lazy as paramedics, and we say in our OSCE or whatever, we say, I'm going to give fluids, so I listen to the lungs, no crackles, so I give fluids. Okay? And it doesn't say presence of crackles. It doesn't say presence of adventitious sounds. It says no signs of fluid overload. And I get it. I'm really trying to stretch my logic here of wanting to be justified in giving a bolus. This is a patch kind of call, and they're going to tell you, no, just take her to the hospital. But fine crackles may be one sign of a fluid overload. Fluid ankle edema may be one sign of a fluid overload. Dyspnea may be one sign of a fluid overload. But you got to look at a whole picture. Because when I look at this lady, spoiler alert, we go to the hospital, they start a central line on her, give her norepinephrine, talk about life support, and give her a 500 milliliter bolus, start a catheter, and then they say, when we get her fluid overloaded, we'll put her on CPAP or BiPAP, and we'll give her Lasix. But we're not giving her Lasix now because she has no fluid in her, and we'll make her map even worse if we turn her diastolic into like 10 or 20 or 30 or whatever the Lasix gets rid of the resting fluid. So if we bring this number down, that's no good. If we BiPAP, we bring that down. We can't do that. Okay, this isn't a good situation. But it starts to make me think about what is the priority here with this patient, okay? And this is beyond the scope of our pharmacology conversation now at this point. But we lay her supine, because that's all we can do for hypotension. So we lay her supine. She's satting at 98. I don't know if we even care about the sat because she's incredibly hypotensive and peripherally shut down. So it's not like there's good blood movement through the SpO2 anyways. And then we say to ourselves, okay, like, how short of breath is this lady? What's the risk of giving her fluid to making her crackles worse? we start to mess with the respiratory system. We start to mess with Henry's law. We start to mess with, diffusion gradients. We start to make her short of breath. She starts to hyperventilate. She's breathing at a normal rate. She's satting well. She's tolerating being supine. She has some, dare I say it, academic fine crackles. Like, they're there. But what are we doing in the meantime while we stand here worrying about making her more short of breath or worrying about her lungs? We're killing her brain. We're killing her heart. We're killing her kidneys. We're killing her liver. We're killing her. As long as we leave this person with a map of 55, we're killing them. So it really makes you think, like, what is the least of two evils? And it's a fluid challenge. It is way less of an evil than making someone potentially short of breath. Okay, so it's a tough one. It's a tough call. My partner shut me down, and I was like, I'm not about to argue because this is way too complicated to really be able to justify the idea of me being like, I think we're going to give her a 500 bolus anyway. And he looks at me like, I think you're trying to murder this woman. All right, maybe. What else does it talk about in the IV? Do you want to look at any IV math? Everybody in here comfortable with math? Okay, very quickly, make sure you're okay to rearrange formulas. So the drip rate, I'm going to do this quick. Who's in the second lab? I'm going to do this really fast. Okay, is the volume. It's better that you got the drip rate lecture because everyone else got an extensive lecture on the endocrine system and the kidneys. Yeah, she had a history of congestive heart failure. Yeah. Not a well lady. Make sure when you get this formula that you're not trying to memorize 4 formulas, that you're okay with going, I'm going to multiply both sides by time. So now I can divide drip rate over here. That is now the formula to solve for time. Cool? Everybody cool with that? Okay, so if we wanted to solve the same formula for volume, okay, we could bring time up. We could bring drop factor down. Now we're solving for volume. Okay, and if we wanted to solve for volume, or sorry, for drop factor, we could keep drop factor over here, drop factor. We could bring time up, and we could bring volume down. Now I can cancel out volume and time, and now you've solved for drop factor. Make sure you're not thinking about memorizing 4 separate formulas, but you just pick one of them. It really doesn't matter which one. You just pick the 4 variables. And then I've shown you guys a couple of times dimensional analysis. I would strongly recommend, if you're struggling with math still, to watch like a half-an-hour video on dimensional analysis so you can just work units out yourself. Okay. All right, I think that's all I really want to talk about for the parenteral part. I have 3 or so topics that I would talk about, probably anticonvulsants, the NSAID, like the inflammation, like the COX cyclooxygenase pathway, the RAS system if you want. I think the RAS system will probably come up in a different lecture anyway, but we could go over it at a quick level. But I've been talking for a long time, so I also would say if there's something you want to talk about or you have a question on anything, this is the time while I drink my water bottle for 30 seconds. You know, one of these days I'm going to get a group of people who ask questions, and it's going to be great.
Sorry, I'm not Wes.
Hey now, keep the videos anonymous. Sadie has a question.
But it's not pharmacology related.
Okay. Cop out. Did you say cop out?
No, I said called him out.
Oh, I thought you guys said cop out. What's your question?
Oh, it's about trauma tours. Is that okay?
Yeah, trauma tours are fine.
Okay, so in the trauma tour, it says like an indication for it is. Hold on, let me pull it up.
Yeah, you should be ready.
Because I'm not trying to say it off the top of my head. Are you pulling it up? Okay, go to the indications for a trauma tour.
Cardiac arrest, severe to secondary to trauma.
Yes. Now go to the tour.
I feel like I don't like where this is going.
Okay, so you see how it says signs of life at any time since fully extricated is a contraindication, so you can't tour them if there's been any signs of life since fully extricated. But then go to conditions. Yeah, no, go down. Okay, so it says. Wait.
So they have to have no signs of life at any time since they're fully extricated to be toured.
Okay.
So one of the contraindications is having signs of life.
Yes. That's. I think I'm confused about.
If you get them out of the car and they like move, or someone thinks they were alive, or you did some CPR and they had some CPR induced consciousness, we're not going to tour them.
Okay.
But if they're trapped in the car and you're doing some like one-handed CPR, or you like show up and you see them and they're like, help me, I'm trapped in the car and I'm bleeding everywhere, please call. And you're like, oh, we'll do everything we can. And then they die. And you're like, they're stuck. You don't have to be concerned about those signs of life because they're still trapped. Okay, so they're not fully extricated yet. So it's all about the concept. The logic is all about time in a trauma tour. Okay, so yes, they were very alive, but trapped. A long time later, they're dead and free. Okay, it's all about time. So they're toast. It's been too long. Okay, but if they're free and they're somewhat alive, well, then time is much less. So we don't want to tour that person. We want to try to take that person to a trauma center or a hospital.
Okay. I was looking at Paraguide too, and I think it's different. So.
There is definitely some wordiness issues in the trauma tour. Definitely some wordiness issues, like the fact that you have to be and, or. Okay, because it's kind of my grievance is that there should be and/ors here.
Yeah, see, okay,
There should be and/ors.
So signs of life when fully extricated, with the closest emergency department being over 30 minutes away, right? So that, like, you can tour them.
If they have signs of life and the emerge is greater than 30 minutes.
But then it says signs of life at any time since fully extricated is a contraindication. So I don't understand why they even put in the 30-minute thing. That's what I was confused about.
Yeah, that is, you should be confused. You should be, because that definitely contradicts itself. I think you would be okay to call for a tour if they had some signs of life and you were over 30 minutes away. That would be how I would read that. Yes, that does sound like it's contraindicated. Okay. But it's clearly trying to tell you, I feel this contraindication, that this contraindication lines up with this phrase, no signs of life at any time since fully extricated. Yeah, so or they had signs of life, but it's more than half an hour away, so they're cooked.
Yeah, that part I got, but then it was 30 minutes away. That didn't make sense to me.
It's wordy. It's weird.
Okay.
Okay, how do people have seizures? Comes back to this guy, okay? Okay, we have an action potential. We have a resting membrane potential of X, okay? I don't care to know the number off the top of my head. Minus 70, I think. Minus 65, minus 60 something, whatever. There's two different ways that we can deal with seizures, okay? We can make action potentials less likely to happen. Okay, or we can raise the threshold. So we could move the threshold up, or we could make the action potential less likely to happen. Okay, so there's two main types of drugs. You've got your drugs that are going to block sodium channel blockers, and if we block sodium channels, then the action potential can't happen. So we can have sodium channel blockers. Block sodium channels. That's your phenytoin or dilantin, carbamazepine, lamotrigine. Or we can mess with glutamate and GABA. On the other hand, we can decrease and increase one of them. If I wanted to mess with glutamate and GABA to make a seizure less likely, where should I put those words? I want less.
Decrease glutamate.
Yeah, we want less excitatory glutamate. We want increased effects of GABA. Okay, this is going to be your benzodiazepines. Okay. Essentially, that's your story for seizures. Okay, draw that little node up for yourself and dig deeper into all those different elements. Okay, we can suppress the activity of the body, or we can block the action potential from being able to happen. You have this little membrane. Okay, this little membrane's hanging out, and it's going to secrete something called arachidonic acid. This has nothing to do with seizures, sorry. This is the inflammation pathway. I'm going through a few different high yield pathways. This is the inflammation pathway. And it's why it's not simple enough to just be like, but isn't ibuprofen and ASA both NSAIDs? Yes, they are both NSAIDs, but we give them for different reasons. And we give them for different reasons because of what we're talking about. What are we talking about right now? We're starting to talk about mechanism of action again, which means we're talking about the pharmacodynamics of these drugs. Okay, so phospholipids, when they get irritated, okay, we stab this guy. That's what that is. It's a sword. Okay, I don't know if you can tell that it's a sword, but it's a sword. You see it now? Okay, that's a knife or a sword. Okay, and we stab this guy, you irritate the phospholipid membrane, and they secrete this thing called arachidonic acid, which goes into one of two pathways. Goes into both pathways, rather. Okay, it stimulates these things called cyclooxygenase 1 and 2. Cyclooxygenase 1 and 2 then causes the synthesis of two different things. That's your hint right there that everything in pharmacology in this entire program is annoying, because the one that they call cyclooxygenase 2 is primarily responsible for one thing, and the thing that they call cyclooxygenase 1 is primarily responsible for two things. Okay, so I don't know, figure it out. That's a hint though, because both of these are going to be prostaglandins. Okay, which causes inflammation. Who studied? What's the main activator? What's the other thing activated in cyclooxygenase 1? It ends with A2. Okay. So you're like, I'm never going to remember that. Thrombo has to do with clotting. Increased platelet aggregation. Okay. Platelets are one part of this thing that's like factor, I don't know, 10 million things that lead to prothrombin, which gets cleaved into thrombin, which cleaves fibrinogen into fibrin, which meshes with platelets to form clots. Okay. Hey, look at that. There's a bonus pathway here now. To break down clots, we use plasmin, which comes from plasminogen. So now we're set up to talk about two different drugs. Okay, so we can use TXA here, which stops the conversion of plasminogen into plasmin, which stops plasmin, which stops clots from being broken down. This is breaking down clots. This side is increasing clots. Okay, so TXA equals more clots, because TXA equals less clots. Okay, minus equals positive. Less clotting, less plasmin, less clotting breakdown, more clotting. Okay, on this side, when we use an NSAID, we can block these pathways. Okay, and aspirin has a higher affinity. Aspirin has a higher affinity for COX-1, increased affinity for COX-1. So they still do both, and that's why you still have to ask about current active bleeding for ibuprofen. But aspirin has a higher affinity for this, which is why since 1980 we moved away from 500 milligrams of aspirin for a headache. You had to take 500 milligrams to be able to do the main inflammatory pathway. You had to take 500 milligrams to deal with your sore wrist because it had a very low affinity. It was not super potent. It still had the effect, but it didn't have the potency for COX-2. We needed way more aspirin to use it as an anti-inflammatory thing, which is why grandma was taking 500 milligram aspirins. Okay, but what do we give? We give 162 milligrams. We give 2 aspirins, right? We give 2 81s. Okay, chew 2 aspirins. We give 160 milligrams to be able to get the effect down the COX-1 pathway. Okay, so it has a higher affinity. It's more potent for the COX-1 pathway, where NSAIDs like ibuprofen and Toradol are more potent for the COX-2 pathway.
We don't give them, but then blood thinners.
Blood thinners mess with clotting factors and stuff over here. So antiplatelet, there's antiplatelets like clopidogrel, and then there's things that mess with all this stuff, which would be like warfarin and Xarelto, which typically mess with the factor, the whole like factor sequence. Okay. Something's still recording.
Yep.
Sweet. You're my camera crew. What cells, what part of the skin is the thinnest in the body? What's the thinnest layer of cells in the body? Epidermis is quite thick. It's 5 layers. There's 3 layers of skin, but the epidermis itself has 5 layers. It's a trivia question, that's all. It has nothing to do with pharmacology. Where's the thinnest part of the body? The thinnest layer of skin cells. Yeah, it's the conjunctiva. It's the eyelids. Fun fact. What cell does not have a nucleus? Hemoglobin is not a cell. Yeah, it's the red blood cells. You're basically right. Yeah, you got that concave the hemoglobin is inside the red blood cell, and by not having a nucleus, you have more space for hemoglobin. Erythrocytes is a very fancy word for red blood cell. So what's the fancy word for white blood cell? Leukocytes. What are different types of leukocytes? Which are all examples of agranulocytes, are all examples of granulocytes, and then your agranulocytes are your T cells and your B cells. That's later. We'll probably talk about immunology at some point. Okay, the last thing I want to talk about, which marker works the best? Can't decide. I think the red works the best. I need a good black. Send me a good black.
I don't have black, but
I don't want it.
yeah, take it.
No, I don't want them. If I ask for black, he says he doesn't have it, and he throws
It's got a dark purple in there.
things at me.
There's like a navy.
Let's try a navy purple. He threw it all this way. Navy purple. It's not a blue. The blue's over on the floor. Oh, that's nice. That's nice. It's not a very good kidney, but that's a nice blue. Okay. We need 2 organs. We need a liver as well. Sideways kidney, if you will. I don't know how to draw. Looks like a stomach. How do you draw a kidney?
Yeah, there you go.
There you go. It's like a bean. Just draw a bean.
They named the... Okay. Where are we going with this pathway? Could be anywhere, okay? Could be anywhere. If you know where we're going already, you're a glorified paramedic student. Because I'm pretty sure if you asked a bunch of pharmacology people, liver, kidney, where are we going? They'd be like, anywhere. But if you're like the RAS system, then you're locked in, okay? You know what we're talking about. The RAS system, okay? So decreased blood pressure in the kidney, particularly what cells? We're going to call that the right word. Okay, decreased blood pressure into the juxtaglomerular cells is going to cause a release of renin, which is going to cleave angiotensinogen. Sneaky, sneaky. Notice how I threw a liver in there, okay, because the liver creates angiotensinogen. Okay, so this is going to cleave angiotensinogen into angiotensin 1. And you guys are locked in on this. I heard vasodilator in the room. That's very bad. You're not locked in. This was a one mark question. At this point in your life, this is a 1 mark question. It's name the renin angiotensin aldosterone system, and then it has A, B, C, D, E, and it just has them all listed in mixed up orders and has vasodilator in there. Okay. So this is only a 1 mark question. Okay, so angiotensin 2 is a vasoconstrictor, and it also increases ADH and aldosterone. Particularly sodium, not just all salts. And yes, when we increase sodium, we're going to decrease potassium. Okay. Angiotensin, let's see if you can figure this part out, okay? Angiotensin 2 blockers manage blood hypertension by blocking the receptor for angiotensin 2. Okay, so the pathway can still carry on. That's a big deal. That is a big deal. We're being quick right now, but that is a big deal. It blocks the receptors for angiotensin 2. Because if it blocked angiotensin 2 formation, that would be an ACE inhibitor. Okay? And that's just the second 1 mark question I stole from you. Okay? Because someone said vasodilator, and then someone said block the formation of angiotensin 2. And now you're that locked in, and you're down 0 for 2 on a high yield section that you studied on. Okay? Where do diuretics work? Yeah, kind of a quick trick question, okay? Because some diuretics work here. Some diuretics could decrease ADH. Some diuretics could be anti-aldosterone agents. Okay, but these are more niche. They're mostly going to work on the actual nephron itself. Okay, so some will work on the loop of Henle. Some will work on the proximal convoluted tubule, some will work on the distal convoluted tubule, and some will work on the collecting duct. Most will work here and here. This is where aldosterone gets secreted. This is where ADH belongs. Okay. ADH hangs out in the collecting duct, puts in more receptors for water, so water can be reabsorbed. And a really fun thing is that in the distal convoluted tubule, aldosterone, the way that it reabsorbs sodium, I think most of you know this now, but in the actual membrane of the distal convoluted tubule, it increases Batman. Okay, it's a sweet half-light. It increases the amount of sodium-potassium pumps. Which I am really frustrated that I learned 2 weeks ago instead of 10 years ago. Because instead of memorizing aldosterone, I don't know why in 10 years no one ever told me that it does that by just putting in more sodium-potassium pumps in the distal convoluted tubule. So after the whole kidney's been filtered and the salt is about to hit the collecting duct to go out into the ureter and down into the bladder, they increase the amount of sodium-potassium pumps, so more sodium binds in here, ATP gets spent, flips it around. And that is why, if sodium is going this way, potassium is coming this way and being excreted out the urine. I don't want to draw the urine structure. So that's why we lose potassium when we're saving things. Okay, and the reason we use sodium to regulate our blood pressure is that it's way less dangerous to mess with sodium levels than it is to mess with potassium levels. Because if you look at that, it's like 130 to 140 or something along those lines. Millimoles is the accepted level for sodium. So you can have like in the hundreds of sodium, where potassium's accepted blood level is like 4 to 5, 4 to 6, okay? So if you start having to be like, oh, I'm a little hypotensive, I'll just retain a bunch of potassium and go into VTAC. That's not super productive. Okay. But if you're like, oh, I'll just retain a bunch of sodium and I'll be thirsty, that's fine. I would also make sure you go through the benzodiazepines, and I think probably better than I can explain it, I would spend some time talking about cholesterol as well. Okay, cholesterol meds are pretty high yield as well. Cholesterol meds can work in a variety of ways. They can increase the utilization of cholesterol, specifically low density ones. They could increase the elimination of bile. Bile is made from cholesterol. So if we get rid of bile, we can make more bile. So we can use up more cholesterol, or we could utilize more cholesterol in our body, or we could decrease the synthesis right at the top. And that's your HMG-CoA reductase. Yeah, so we would inhibit that if we wanted to decrease that. Okay, without decreasing that, without inhibiting that, that's what this enzyme does, is synthesizes LDL. This you? Or him?
Him. I was just like...
Here's your Gucci mango purse back. All right. Any thoughts, questions, final things you wanted to talk about?
Can you explain just why, I think you mentioned earlier, why cardiac ischemia was altered and then
Cardiac ischemia, pulmonary edema, you can be altered. You have to be unaltered.
you want it?
No, I'll use light purple now.
Mango?
This one's too squeaky. What's the risk of nitroglycerin? Yeah. So good, we like this. This one's like, this navy is a class favorite, okay? Maybe for Christmas I'll get the 25 pack instead of just the bulk, same 4 colors. A girl did give me 4 markers this semester. I don't know who's in the first lab, but I got a 4 pack of markers like week 3, so that was good. Okay, so altered, unaltered as a condition. The question is why, the rationale for the directives, okay? So the risk of nitro is decreasing blood pressure. Okay, so we don't want you to give nitro if they're hypotensive. That's what it's saying. Don't give if patient hypotensive. So for cardiac ischemia, if they're hypotensive, they're in bad shape. And if we make them more hypotensive, that's really bad. We don't want that to happen. Okay? So we say, don't give them nitro unless they're unaltered, because it serves as a secondary check. If unaltered, BP most likely high, okay? Because cerebral perfusion pressure is okay, right? They have a blood pressure. They're unaltered. They have a blood pressure. This person is altered, but you can still give them nitro. Okay, well, long story short, being in congestive heart failure, we talked about that lady, okay? Really the only way to be hypotensive and have fluid in your lungs is to be dying. Okay, that means your heart no longer can pump. That's where your blood pressure went. Really, the average person who is in, or the mainstream idea, the archetype of a congestive heart failure pulmonary edema patient is a hydrostatic problem. It's a pressure problem. So to be in pulmonary edema, you have a high blood pressure. Okay, I just gave you like a 20-minute rant about a lady who was in pulmonary edema and had no blood pressure. She was dying. Her heart was giving up. She needed vasopressors. She needed something to make her heart pump more. She was dying. Okay, but typically you have a high blood pressure because pulmonary edema is a hydrostatic problem. Not an osmotic pressure problem, a hydrostatic pressure problem. Okay, so if we're altered, but we most likely have a high blood pressure because the person's drowning on their blood right in front of us. That lady that I talked about was not drowning on her blood right in front of us. She did not have enough blood pressure to flood her lungs to the point of respiratory distress. She had a lack of heart enough that it was starting to back up. Okay, but she didn't have so much blood pressure that she was drowning in fluid, okay, across the whole thing. So if you are altered, and it's got to do with gas exchange, then you're altered because of hypoxia. So if you're altered because of hypoxia, if we can reduce your blood pressure, we can reduce your pulmonary edema, we can reduce your hydrostatic pressure, we can increase your oxygenation, we can decrease your alteredness. Okay. So nitroglycerin for altered is because of the differential of hypoxia. If you're hypoxic in a cardiac ischemia, we know you're hypoxic in a cardiac ischemia, but not your brain. Okay? And if we make you hypotensive when your heart is already struggling to get any energy, your heart's toast. And then you'll end up like in pulmonary edema because your heart will fail because you starved it of oxygen. Okay? So think about the two as one of them is most likely a blood pressure is keeping you alive, and one of them blood pressure is probably killing you. And the reason you're altered, if it's cardiac ischemia, you're probably altered because you're hypotensive. So we don't want to give you nitro because that is the risk of nitro. But if you're hypotensive if you're altered in a pulmonary edema case, it's probably because you're hypoxic. And in that case, nitroglycerin will treat the hypoxia. Okay. So unaltered in a cardiac ischemia is a safety feature to stop you from giving something to somebody who's like a right-sided failure or unconscious on the ground. Time for me to mention that the coolest thing I've ever seen done in an OSCE, and then we'll finish with this story. The coolest thing I've ever seen done in an OSCE just happened the other day. So I made this scenario. I didn't make it. I slightly tweaked it. I made it more fun. I bring props in. Okay, I'm a big prop guy. Real big prop guy. So we have a guy who dies in the library. So I went and got like 30 textbooks. I got like 30 textbooks, and I got a skeleton, and I got like all these things, and I knocked them all into the library. I said, oh, this guy, he's an old guy. His wife died 3 years ago, and he told me that his goal was to read every book in the library. Okay, that's what he wants to do. And tonight, he came by a half an hour ago, and he was reading. And I saw him fill up his water bottle. He always comes and tells me about the book he's reading, but tonight he was just gray and sweaty, and he just like sauntered back to his little study room that he books out. And they're like, oh, do you know him well? And I'm like, he comes here every day for 3 years since his wife died. He says he's going to read every book. I know him so well. I'm the best librarian ever. I care about my readers. Okay. And the guy's like, okay. Do you know if he like has any problems? I'm like, oh yeah, he always like rubs his heart and just like hits this candy spray, and then he feels great. He's good to go. It's the first semester scenario, so they haven't learned about any of this stuff anyway. So I don't know why this individual thought it was the way to go. But they're like, did he do that tonight? And I'm like, no, I didn't see him use it tonight. But normally when he uses it, fixes him right up. Okay, I think it's called like nitroglycerin. And he's like, oh, do you know like if he has it? And I'm like, oh yeah, he always keeps it in his right pocket. So the guy reaches down on the mannequin, and he's like, check the pockets, man. So I'm like, you find a bottle of nitroglycerin. And he's like, oh, the guy's dead. We're doing an arrest, okay? We're mid-arrest. We're like 6 minutes into this arrest. He finds the bottle of nitro. First semester, he's got his partner doing CPR. He's up on the airway. I'm like, you got the bottle of nitro. You found it. And I'm like, I'm good for him. Incident history, finds medication, searches patient. I'm like, these are good things. So then he goes, all right, I'm going to give it to him. And I was like, sorry, what? And that was his flag to be like, that's abnormal. I was like, sorry, what? You're going to give it to him? And he's like, yeah. And I'm like, you want to give it to him? He's like, yeah. I'm like, do it. Yeah, do it. Do it for real. So he's like, pretends to pop a cap on this nitro, moves the BVM, just doses this guy, doses this VSA, hits him with a tap of nitro and carries on. I got a lot to type about that. I'm sorry, son, I got a lot to type about that. Never before have I seen someone nitro a dead guy. That was the first time I saw that one. I also watched a guy run a trauma arrest 6 interpretations. I had 2 arterial bleeds that were they were spurting when he did CPR. And I even prompted him. I was like, you can see the level of spurting stopping. And he's like, good, the bleed is controlling itself. And I'm like, you're not going to dress those? And he's like, we'll dress them in the truck. We don't have time for that now. And then he worked the call for 20 minutes on scene before he left and never dressed the 2 arterial wounds. And side quest, you didn't know that the airway was full of blood until 9 minutes. And he didn't do anything about it till 14.
How long are the questions today?
They have 17 minutes there. Anyway, lots to think about, lots to learn. Don't stop learning. We'll catch you next time, session 4.